with that, I want to move now to the second line setting. So we've talked about all this change in landscape in the frontline setting, the use of now and really pretty, rapid uptake of these TKI IO combinations. Right now, it's axitinib and either pembrolizumab or avelumab, but there may be more coming. And we mentioned this checkmate, Niner study, and there'll be other studies with pembrolizumab and lenvatinib and others. So I want to think now, as we start to use more of these combinations in the front line setting, what does that do to our second line setting? How are we thinking about second line therapy now in renal cell carcinoma? Does it mean we have to start all over again? Can we apply some of the older data? What are some of our goals in these second line settings, and how do they differ from the front line settings? And what's really the impact now on sort of the tolerance and quality of life of patients in second line and beyond? Raj, you want to kick us off in this area?
Yes, a very interesting question. Nivolumab obviously was one of the standard second line agents until just last year. And now with ipi/nivo being used in first line, or axi/pembro, and soon cabozantinib-nivolumab combination, I'm sure it will show fantastic results based on the known efficacy of cabozantinib as a single agent in TKI, which you have established in the first line setting. What is the role of nivolumab in second line? So I really, unless we see, we are seeing re-challenge data, like the data which are coming up after using these PD-1 inhibitors again in second line after prior use of PD-1 inhibitors in the past. But most of them are being used in combination with VEGF TKIs. So right now, if you ask me second line nivolumab, what is the potential, or what is the market, or what is the use of second line nivolumab in my practice? Pretty much nil, nothing. Because most of my patients are getting one of the PD-1 axis inhibitors first line, barring few patients, small number of patients who are getting single agent VEGF TKI. But in those patients, sometimes I tend to use second VEGF TKI again because they're responding so well to the first VEGF TKI. So that's how it is panning out. So with axi/pembro being used in upfront, or ipi/nivo being used upfront, I think the default choice for me is cabozantinib, is second line. I think this is the most efficacious monotherapy in metastatic RCC. And once patients progress on cabozantinib single agent monotherapy with cabozantinib, the most commonly used regimen in my clinic is lenvatinib with everolimus. Now, if cabo-nivo combination gets approved next month, I hope, and I start using cabozantinib plus nivolumab combination in first line, I'm going to really struggle with, because I'm sure this is going to be a very effective combination based on whatever experience we have with these two drugs. So really the second line agent may end up being lenvatinib with everolimus, or lenvatinib with pembrolizumab if it gets approved based on second line data presented in ASCO. So I think it's going to be fascinating to see how things are going to evolve over the next 1, 2, or 3 years.
Fantastic. Let me just ask one quick follow-up question, because we talked about IMDC in the frontline setting. Is there an IMDC in the second line setting, and do you use it, and how do you use sort of risk stratification in the second line setting?
I don't use it.
You don't use it? Okay.
No. I only use IMDC in first line setting. So
in the second line setting, you really kind of treat them all pretty similarly?
Yes. I don't use them, treat them. I don't treat them similarly. I look at many other nuances. For example, what kind of drugs have been used in the past, performance status, patients' wishes, their choices, and so on. But I think IMDC criteria doesn't play much role in second line setting as it plays the dominant role it plays in first line setting in my clinic. It doesn't have much role in second line or third line setting.
Monty, any thoughts on this? Any risk stratification?
Yeah, no, I tend to agree with Niraj. I definitely think that although you certainly can opt to use the IMDC second line criteria, it's that clinical nuance that sort of helps me decide what treatment to allocate patients to. At this point in time, I don't think the second line IMDC criteria are refined enough to help us allocate to one treatment or another.
It's interesting, isn't it? Because it seemed like it had some relevance early on when we were using just TKI monotherapy, but now that we're using these combinations in the frontline setting, it's almost like everybody that progresses is kind of at least an intermediate risk. There's at least, some biology there that's a little bit more aggressive. And, it's also, interesting to me, there's been some data out about re-challenge with agents. For a long time, we've known you can re-challenge with TKIs and you can use different TKIs one after the other. In fact, some of these drugs got their approval in the setting of, frontline TKI failure and then, a subsequent TKI. And now we're beginning to see some data with IO studies that you can challenge with one IO after another, maybe with a treatment break of something different in between, but that there can be, continued response. So at least therein lies the hope, Niraj, that even though we're using maybe some of our best agents up front and best combinations up front, that we're not, we're not emptying the tank. There's still opportunity to revisit these strategies, maybe in newer combinations over time, kind of get, continued, maybe not complete responses, but at least some disease stabilization and clinical benefit.